Good afternoon to the participants in the room. Good morning, afternoon, or evening to those who are joining online. Thank you very much for being with us today. My name is Valentina Pomatto, and I'm the Advocacy Manager at Humanity and Inclusion, also known as Handicap International. First, before starting, I just want to thank the Civil Society Engagement Mechanism of the UHC 2030 Coalition for offering us this very nice venue and for all the support provided. And I also want to thank the co-organizers of the side event in alphabetical order: 80 Scale, the Global Partnership for Assistive Technology, Global Cooperation on Assistive Technology, Humanity and Inclusion, International Cerebral Palsy Society, and the World Rehabilitation Alliance. Just to put all of us in the mood for the session, I would like to ask you two questions before we start. Have you ever needed rehabilitation, whether it is physical therapy, speech-language therapy, exercises for coordination or memory, or assistive technology, whether it is crutches, hearing aids, screen reader, wheelchair, glasses during your life? Can you please raise your hand if you've ever needed? Okay. And also for participants online, just type if you have ever needed rehabilitation or assistive technology during your life. And the follow-up question is, do you know someone who has needed rehabilitation or assistive technology during their life? Okay, I think that's a very strong answer from the room, and your responses demonstrate that rehabilitation and assistive technology concern a very large number of people. Anyone might need rehabilitation or assistive technology, or both of them, at some point in their lives. So rehabilitation, maybe we can go to the next slide so we dive in. You already see that there is captioning on the screen. If you want to access captioning on your phone, you can access the Zoom link, and there's a QR code for those who need that. Yeah, we can move forward. Thank you. So just a few information to set the scene for the conversation that we're having today. Rehabilitation is defined as a set of interventions designed to optimize functioning and reduce disability in individuals in interaction with their environment. Assistive technology is an umbrella term for assistive products and their related systems and services which help maintain or improve an individual's functioning related to cognition, communication, hearing, mobility, self-care, and vision. By improving functioning, both rehabilitation and assistive technology enable people's health, well-being, inclusion, and participation. They help a child, adult, or older person to be as independent as possible in everyday activities, and also enable participation in education, work, recreation, and meaningful life roles, such as taking care of family. Growing rates of non-communicable diseases, disabilities, injuries, and chronic conditions mean that more people than ever need today rehabilitation and assistive technology to function and to participate in society. We're speaking of 2.6 billion people in need of rehabilitation and 2.5 billion people in need of assistive products. Yet, both rehabilitation and assistive technology remain underfunded and reprioritized in health systems. Health systems still focus mainly on disease treatment, leaving access to rehabilitation and assistive technology quite patchy and unaffordable, especially in lower middle-income countries. Integrating rehabilitation and assistive technology in universal health coverage is key to building more inclusive and people-centered health systems. This year, World Health Assembly is an important moment for both rehabilitation and assistive technology because the reporting on these two topics is on the agenda. And we also know that in 1 year and a half, there will be the UN high-level meeting on universal health coverage. So it's a good time today to speak about rehabilitation and assistive technology in the context of universal health coverage. Without further ado, I'll introduce the first speaker, and I thank all of them for being here with us today. Yeah, we can. The first speaker today is Kaylee Shea. She is team lead for access to medical devices and assistive technology at the World Health Organization. The question that she will answer is, how does the WHO GATE 5P framework on assistive technology help guide countries on strengthening access to assistive technology within universal health coverage? And also maybe just a word before about what the WHO GATE 5P framework is, for those who are not familiar with it. Thank you very much.
Thank you. Thank you very much, Valentina. And it was a really good setting the scene, so thank you for that. Now, I'm going to copy what you did earlier and actually just ask, first of all, who in the room has heard of the WHO 5P framework? Hands up. Heard of. Okay, so, right. So then if I ask, can anybody in the room name all 5 Ps? Don't name them, but anyone, if you feel confident that you could. Keridwen's pretty good. Emma is on my team, so I wouldn't expect any less. And also online as well. It would be nice to kind of capture that. Okay, so I'm not going to tell you what the 5 Ps are. It's in my speech. The 5P framework, there's 5 Ps. So at the end, I will ask you if you've picked up on the 5 Ps. And that way, despite the room being super hot, I'm fairly sure I'm going to keep you awake. Okay, so thank you very much for the question. And what I'm going to do is talk a little bit about how the framework helps guide countries, and then also give some examples of how it's being applied in practice. So a key feature of the 5P framework is that it offers countries an accessible model that resonates beyond health systems, and that is a very deliberate strategy. So when the framework was developed to help countries strengthen access to assistive technology, it recognised that while this is a health issue, it is also a multi-sectoral issue. So we wanted a framework that could speak to everybody. Because if we want universal health coverage to be truly universal, then we need assistive technology to be built into the health system, but we also need access to be supported through coordinated action across sectors. And we know, and it's been said now, that too often assistive technology is approached in a very fragmented way. Responsibility is often split across health, social, education, labour sectors. Policy is developed in one place. You have products that are being considered somewhere else. Services are uneven or unavailable. The workforce capacity across sectors is really limited. And the people who need assistive technology are not consistently involved in decisions that affect their lives. And so the result is that access to assistive technology remains inequitable. So the 5P framework brings these pieces together into one coherent, multi-sectoral approach. Now, I'm going to give you a hint that you're going to hear the Ps now. So it puts people at the centre of the framework, and it encourages coordinated action across 4 connected areas, and these are policy and finance, products, provision, and personnel. And in this way, it helps countries move beyond an individual product or isolated initiatives toward a coordinated reform across systems and sectors. Right. The framework really does help countries to embed assistive technology into policy, planning and finance, including universal health coverage benefit packages, for example. It helps improve access to priority, quality-assured products, strengthens provision systems across health, rehab, primary care, education, aged care and other sectors, and to build the workforce or the personnel that are needed. So in summary, it's a structure that gives countries clear direction to be able to identify where are the gaps by using that framework, to set priorities across the framework, and then to take coordinated action. So in practice, the 5P framework is well tested. It was developed in 2014, so it's been used by many countries, and they are moving forwards with their system strengthening, referencing this as a framework. And for WHO, we have deliberately structured our tools and our resources to support action across the framework. So for example, WHO's Priority Assistive Product List, or the APL, has helped establish a global reference point for the products that should be available as part of a functioning system. And many countries have or are in the process of developing national priority lists that in turn guide the system planning needed to support provision of these products. So we're aware of at least 25 countries that have national priority lists built on the WHO blueprint, and there are others that we're not aware of, and there are more in development. The WHO Assistive Technology Data Toolkit, which includes the RATA, so the Population Survey on Need and Unmet Need, and the UHC, or the Situation Analysis, is structured around the framework, and it supports implementation across each of the Ps. For example, if we think about data, better data helps countries strengthen their work under the Policy and Finance P, including planning, monitoring and accountability. And information about population need for priority products can support workforce planning under the Personnel P. And one of our most visible tools, Learning on Tap, has been developed to support task sharing of specific assistive technology roles with primary healthcare personnel. And further, the forthcoming global roadmap for universal access to assistive technology, which is being co-published by WHO, UNICEF and UNDESA, also uses the 5P framework as its organising structure. Building on the global report on assistive technology and further consultation throughout 25, the roadmap translates the framework into 21 recommended national actions across the 5Ps. And these provide a practical agenda for countries to strengthen access to assistive technology through leadership and governance, financing, priority setting, procurement and supply, service delivery, workforce development, data and evidence, and meaningful engagement of assistive technology users and their respective organisations. So just finally to add that this work sits within a broader global mandate. The adoption of the 2018 World Health Assembly resolution on improving access to assistive technology made it very clear that assistive technology is not a peripheral issue, but a health, development and human rights priority, and it called on member states and partners to strengthen access. So with the 5P framework, we can help countries to operationalise that commitment through health systems, through universal health coverage, and through broader multi-sectoral action. So in summary, the framework connects commitment to implementation, and it helps countries move from fragmented efforts to coordinated action, and to see assistive technology not as an add-on, but as an essential part of equitable, people-centred systems and societies. And if I can just grab an extra 20 seconds to now check that the room was listening. And so what was the first P? People. Thank you very much. What came next? Policy. Yay! And then after that? Product. Whoa! And then fourth? Provision, and followed by personnel. And we can often bring them together in discussion, but thank you. You're an amazing group. I hand you over to the next speaker. Valentina, I think.
I think we all passed the exam, right?
Yes.
Okay. Okay. Thank you very much for this overview and also for sharing about the forthcoming roadmap. I think we can move also now to the next speaker, Amy Jo Collins, coordinator of the World Rehabilitation Alliance at the World Health Organization. Thank you. And the question for Amy is, what are the key levers and challenges to establishing rehabilitation as an essential component to universal health coverage? One that addresses not only or just survival, but how well people are able to live. That's an important question for you. Thanks.
Great. Thanks for the question. And yeah, it feels 4 to 5 minutes, a bigger question. So I hope we can get back to it in the discussion. So with my WHO hat, just thank you to partners and colleagues, of course. And with my WRA hat, thank you to all the members in person that are here in Geneva and of course online. So the frame today, the 2023 UN Political Declaration on Universal Health Coverage is titled, and I'm quoting, "Expanding Our Ambition for Health and Well-Being in a Post-COVID World." So UHC has named its purpose, and inside that declaration, rehabilitation and assistive technology are both named specifically. So the question isn't whether rehabilitation belongs in UHC anymore. We know it does, it's there, the language is there. The question is really, is UHC actually architected to deliver on what it's named to do? Now, before I go into that, a quick word on the World Rehabilitation Alliance. It's a WHO-hosted global network set up in 2023 under Resolution 76.6. Over 120 members now across UN agencies, civil society, professional associations, academia, the private sector. It's a convener, it's powerful and growing, and so proud to be a part of it. Now, the pathway matters. 2017, Rehabilitation 2030. 2018, Resolution 71.8 on assistive technology, which produced the WHO and UNICEF Global Report in 2022. 2023, we see Resolution 76.6 on strengthening rehabilitation in health systems. So for the first time in 75 years, we have rehabilitation recognized as a core global public health priority. So a huge feat. 76.6, so the resolution, it recalls 71.8 in its preamble. So through it, it weaves in assistive technology, and it writes the WRA into the resolution itself. Crucially, in this, 76.6 has a reporting mechanism. So many of us are here, the WRA, to report back 2026, 2028, and 2030. So the political mandate is there, the reporting cycle is there, the accountability mechanism is there. But something to reflect on is what actually is being reported back onto. If we look at the scale, 2.6 billion people would benefit from rehabilitation. So 1 in 3. 2.5 billion need 1 or more assistive products. So those are overlapping populations, both defined by a health condition that affects their functioning, both rising sharply with aging and NCDs. Now, the architectural question, UHC's accountability is SDG 3.8.1. I know I'm talking a lot about the resolutions and the numbers, but it is important because that is the service coverage index, 14 tracer indicators. Of those 14, 11 sit in disease areas where the SDG framework also measures the population outcome. So maternal mortality, HIV incidence, TB incidence, NCD premature mortality. Each tracer is meaningful because it points at a measured population outcome. The other 3 are service capacity indicators, not pointing to a population outcome, but I will come back to that. So rehabilitation isn't in the 14, and if it were, it would be a coverage indicator, because functioning, what rehabilitation is meant to measure, is not included. So we can report on 76.6 implementation, 2026, 2028, 2030, and tell the Assembly what is happening in country. But what is UHC actually delivering on for rehabilitation and assistive technology? Now, there's 2 layers of work that flow from this. The first, of course, is technical, which is potentially getting a rehabilitation indicator into 3.8.1. And the rehabilitation indicators, which we'll hear from in a bit, do make that possible for the first time. And there are those 3 service capacity tracers, so health worker density, hospital bed density. But there's also other entry points, which is that recognizing functioning as a measured population health dimension alongside mortality and morbidity allows for rehabilitation to be measured as a functional outcome. So back to the question, what are the levers and challenges for rehabilitation in UHC? The levers exist. We have the resolutions. We have a reporting cycle. We have a network. And in 2027 is the next high-level meeting on UHC. So that is the window. The challenge is that what it is named to do, increase health and well-being, functioning is what makes that possible. Rehabilitation is the health strategy aimed at functioning. And UHC has not named rehabilitation in a way that really matters. So when we look at 2027, it's really what gets measured is what gets reported. What gets reported is what gets funded, and what gets funded is what gets prioritized. So functioning, sitting outside the system that shapes financing flows, and rehabilitation is currently sitting within that. So I hope we can continue this conversation as functioning as a third dimension of population health. Thanks.
Thank you very much. I now give the floor to Pascal Bilveld. I hope it's correctly pronounced. CEO at AT-Scale, the Global Partnership for Assistive Technology. And the question for the CEO of AT-Scale is how can partnerships and strategic investments accelerate access to assistive technology and also support its integration in universal health coverage?
Thank you very much, and good afternoon, everyone. I'm Pascal Bielefeld, heading up AT-Scale, and as our name indicates, we are all about partnerships. And that's really important because I think the challenge that needs to be addressed cannot be addressed by any single organization or any single person. It really requires a truly collective approach through a partnership. And let me just remind you also of the scale of the challenge that we're talking about when it comes to access to assistive technology. We heard 2.5 billion people need AT across the world. In low-income countries, barely 10% of those who need it have access to it, compared to 80 to 90% in high-income countries. So that's the scale of the challenge that we're really trying to solve for. Now, what can we do to try to make it easier to integrate rehab and AT in universal health coverage? You mentioned, or you asked about strategic investments. I think we've tried through the partnership to do just that at the global level and at the local or country level. At the global level, a couple of examples of strategic investments I think that we've made since we began our journey. One was, and that was our first investment, was to actually develop an investment case to really make the case for more investments in assistive technology. And that case demonstrated that there is actually a 9-to-1 return. For every dollar that we invest in assistive products, there is a $9 return. But we've made other strategic investments at the global level, including working closely with WHO and other partners to generate more evidence, to develop guidelines, training packages, to work on expanding the product catalog so that assistive products are now included, which has helped reduce the price of some of these products. So those are examples of some strategic investments that we've made globally. Locally, we've also begun to work in a number of countries across the world. In Rwanda, for example, on the ear and hearing care side of things, we've supported the country really develop a district-level service model, which also includes, by the way, local production of ear molds. And through that support, we were able to ensure that Rwanda could access hearing aids for a fraction of the cost of what they were previously. To be precise, a 94% reduction in hearing aids. And that in turn has allowed Rwanda to now include this in their community-based insurance scheme, right? And so you can see the logic then of how then that contributes to making sure rehab and AT is included in UHC. Another example, Senegal, working with WHO, UNICEF, and other partners in the government there, we've included rehab and AT in the DHIS too. Because as we've heard from Amy, what you can't measure, you often can't fund, right? So again, a concrete step towards greater integration. I don't want to take too much time, so let me just maybe conclude by reminding everyone, I guess, that UHC really is about everyone, everywhere. And without assistive technology, we'll never reach everyone, and we'll never be able to leave no one behind. If a child survives polio, it's a great thing. But if that child then can't reach the school because he or she doesn't have braces, then it's actually a bit of a failure. So let's not forget that. And again, it's only through partnership that we will be able to accelerate that pace of change, because partnership also allows us to de-risk investments, allows us to reduce overall costs, and ensures that we have a holistic and integrated approach. Thank you.
Thank you very much. We have heard from experts from the rehabilitation and assistive technology fields. Now it's time to hear from experts on universal health coverage and global health. So I'm pleased to give the floor to Waiswa Nkwanga. He's the Senior Technical Advisor and Coordinator of the Civil Society Engagement Mechanism for Universal Health Coverage 2030, hosted by Management Sciences for Health. And so we really go into the 2027 UN high-level meeting. What policy entry points can help strengthen recognition of rehabilitation and assistive technology in the lead-up to this important high-level meeting? Thank you.
Thanks, Valentina. So just to give you understanding of where I sit within the UHC movement platform, I sit with the Civil Society Engagement Mechanism. We're a network of over 1,700 members, and we represent civil society in UHC 2030. So we actually, our job is to influence UHC 2030, just like you would influence UHC 2030, to make sure that civil society voices and communities, including this community, that their voices are heard. So what I'm going to share here is going to be based not as UHC 2030, but more as an advocate and how I see the opportunities for ensuring, we do have, as you mentioned earlier, we do have rehabilitation in the political, the last one. And you see this with these negotiations that you keep hearing your issue, seeing your issue, but sometimes you go in, there's another process and it's gone. And so advocacy becomes really important. So it's great that we have a place to start in this process, that it's in the political declaration. It's established language. You want to work with established language, and that UN processes recognize and are willing to maintain, to keep. So we have an upper, we're a step ahead in this process. Now, what are the kind of practical steps, opportunities that we see? There are about 3 processes from my observations, 3 or 4 entry points. So you have the entry point around influencing the constituency itself. So in this case, it's the UHC 2030 that is the technical lead in this process. You have the next level, which is going to be the preparatory processes for the UN, President of the General Assembly, influencing that. And then after that, you have the negotiations. Now you're at the level of member states. And then the third one is really, showing up and showing support during the actual HM. So for each of these, I can mention a few things we can really be thinking about. For the UHC 2030 process, we have started, or they have started, we are part of it. So we have studied the process where we're thinking about and talking about and discussing what we need, how we need to make the commitments bolder and more action-oriented. And I think for all of us, the challenge we have is the issue is recognized, but there's no action. And it's like over and over. And so how do we do things differently this time, being very specific on what we want governments to do? And that process has kicked in. UHC Student Fed has put together a task force that is comprised of the different members, select members of the UHC 2030 Steering Committee. So you have civil society, you have member states, you have foundations and other agencies that are part of that group. So each of these groups has a representative in the task force. They also have other partners and networks, board networks, that are part of the task force. And I'm not sure if the RA is part of it or not. Probably not. So what that task force is going to do is they're going to, and they're drafting right now, the initial document that then will be consulted on with different groups, including our group here, for feedback on how we shape those asks, the key asks from the UHC movement. And that's a critical process because it will be the first document that we will put forward to the President of the General Assembly in March for how the process, we suggest what the process should reflect. So it's very important that in this process of developing the key asks for UHC movement, that we are hearing very specific asks from this community of what we want to be reflected in these asks. So that's first step. The second step, when we come to the preparatory process, and that document is handed over to the UN at the President of the General Assembly, they will look at it and they will figure out how they want to use it when the next major important moment comes in, which is the multi-stakeholder hearings. And those have two parts. So you have the part where we've presented, that they're going to take that document and set it aside. There will be asks from the different constituencies, including our constituents here, that we need to engage, be present, and make very specific asks ourselves during the hearing. And if you don't get a mic to deliver it on a mic, you can actually submit it, and it will go into the report that will become the zero draft of the process for negotiations. So those are things that we can do. We need to prepare the messages for these two processes far in advance. We need them now, and we need to start pushing those moments now. In between, there will be key other global and regional moments that are equally as important. Because what I've seen in the past is that what happens is that people are talking to each other. So you have the UN systems and processes. They're talking to G7, they're talking to G20. Everybody's making calculation of what matters to the heads of states that they have to really make sure ends up in this process. So we'll have to also be thinking through how we engage in those platforms, through the C20 for civil society, through the C7 as well, to make sure that this is on the priorities and agendas and attention of the G20 and G7 leaders. Once they say no, usually you can't really get it out. Then there's also the regional level in entry points. So in Africa, you'll find that they have key moments like the Conference on Public Health in Africa, which is coming up in October, where you get all these ministers and sometimes presidents present, and you want to make sure you are sending the messages and they're hearing it. And there will be the Africa Health Agenda International Conference, also a very key moment to mobilize low and middle income countries to get the same voice, and messages sent across. Then we come to the most important part. So we can have all the language reflected in the zero draft. It can be thrown out during the negotiations. China says, I don't want this. Russia says, I don't want this. And so really building the support of member states working with missions, country missions, especially in New York, but also in Geneva. They also sometimes transmit this over to New York, and making sure that you're keeping them engaged and keeping attention. When the language is out, you ask them, give them a call, give them an email, and ask them to fight for it to go back in. Or it's still in there, but it's not in the way that you want it framed. And so making sure that the framing of it is right. That's the level we can do at that political sort of like engagement at that point. And then obviously the UNGA entry point itself in September. So I don't know if that answers the question, but that's how I see the entry points that we have and the opportunities that we have.
Thank you very much. I think it was a very comprehensive overview. We certainly don't miss entry points, and I can already see quite a lot of work ahead of us as advocates. Okay, well, we'll now have a moment for audience interaction, and we'll have our last speaker after this interaction with the audience. So we are keen to hear from you, but maybe before we have someone who wants to connect, and we can give briefly the floor to Wouter.
Wouter,
Thank you.
I think you should be able to unmute yourself.
Yes, I can. Can you hear me all right?
Yes.
Wonderful. And congratulations on this great session. This is Wouter de Groot. I'm a technical advisor for the WHO Rehabilitation Program. And thank you for giving me the floor to address this particular audience and this session. And just a quick reminder, the definition of universal health coverage includes rehabilitation in the sense that people should have access to the health services they need when they need it. They should be of quality and without financial hardship. And rehabilitation is an integral component of our own definition, that is the WHO definition of universal health coverage, and recognized as an essential health service. Unfortunately, in many countries, rehabilitation services are not prioritized or considered essential health services. We do know there's huge unmet needs for rehabilitation, that maybe less than 50% of people that need rehabilitation. And of course, the aim of the WHO Rehabilitation Program is to support countries with strengthening their health systems, to provide rehabilitation, to integrate rehabilitation across building blocks. One example is the WHO tool, the package of interventions for rehabilitation, that has been used to develop essential packages for universal health coverage. In Georgia, for instance, the Universal Health Care Program did not include rehabilitation services, mostly paid out of pocket, and our WHO tool could be used to integrate and finance rehabilitation services to make them accessible to the population. As an example of how the WHO Rehabilitation Program works to strengthening rehabilitation services. Now, I have been asked to address the indicator question regarding universal health coverage for rehabilitation. And some nice publications have come out demonstrating how current metrics measuring universal health coverage do not include rehabilitation, although an essential service and included in the definition of universal health coverage. And the latest iteration of the Universal Health Coverage Index published by WHO, again, did not include a rehabilitation indicator. Often, and in this case, resulting from the fact that there was no appropriate indicator to suggest, nor available country data. But this is now different. Following the resolution in 2023 by the World Health Assembly for rehabilitation, we have published an indicator that is perfectly fit to include in a universal health coverage metric. That is the effective coverage indicator of rehabilitation. And that publication is available from the WHO website. So this is a call to all countries, stakeholders, to conduct a household survey to assess and evaluate effective coverage of rehabilitation. And why effective coverage? Because universal health coverage is about the people in need accessing services of quality. And there's this one key indicator type that can measure the same, and that is effective coverage. Acknowledging that universal health coverage metrics still include indicators that are not effective coverage indicators because not available from many health programs. And these may be crude coverage indicators or core resources densities, as suggested by Amy earlier, which is still possible. But we do have an opportunity that is the effective coverage indicator of rehabilitation. And if countries start collecting, finally, rehabilitation may be included in the next iteration of UHC indexes. Thank you for this moment. Thank you.
Thank you very much. I invite participants in the room. If there's any question, we can come to you with a mic. Yeah. Hello. Yeah.
Thank you so much for this amazing panel. My name is Bina Kamath-Rain. I am a neonatologist by training, and I work at the American Academy of Pediatrics, but also work with the Cerebral Palsy Alliance Research Foundation. My question is for Kylie. So I am very used to many discussions around neonatal resuscitation and products to improve neonatal survival. And I was curious about the applicability of the 5P framework for products like that, and whether you see any differences, and are we not partnering with other groups to do this type of work? Like, are those missed opportunities?
Thank you. Can I just ask you to give me an example of just two products that you mean in that context? I'm trying to identify whether you're talking about medical devices or assisted products, and then I can answer.
So when I think of some of the products that we're using, for example, a bag mask device to give newborn resuscitation, or a suction device for resuscitation.
Okay, great. Thank you. That clarifies completely. So you're speaking about medical devices, and it just so happens that I now am actually a team lead for medical devices and assistive technology. So there is some overlap. If we think about the challenges in terms of access to medical devices, and having taken this portfolio on sort of in full about 6 months ago, I see that all the time. So, issues like donations, for example, which is a problem across assistive technology, and it's a problem for medical devices. That's really common. Supply chain disruption, local production making these things less expensive, regulation, which is more of an issue on the medical devices side than it is on assistive technology. But there's a lot of similarities. I think where we see a difference, and one of the reasons why I keep the conversations to some extent slightly different, slightly separate, I should say, is the people-centered piece. Because assistive products are used primarily by the individual to improve the individual's function. So in your situation, supporting a neonate to survive, you need access to medical devices, and the person at the center of that, to be honest, is the practitioner. It's the medical health provider that needs that device right now to meet the healthcare needs of that person in front of them. Whereas an assisted product is something that belongs to the person and is very, very personal. So in answer to your question on the framework, in that instance, we would be using the health system framework, and we've borrowed from that to develop the assisted products. The GATE framework, or the 5P framework, where we've really deliberately put people in the centre. But I'd be interested to talk to you about your issue, the issues in terms of access to those devices, because with my new hat on, I'm very curious about where you might see gaps in lower middle income countries for that kind of technology. Thank you.
Okay, thank you and I think there's also a hand raised for later. Thanks.
Should I? Hello, I'm Pradeep. I'm representing Global Mental Health Action Network, but I'm an occupational therapist by profession. Yeah, so frequently see that people who need assistive technology, assistive devices are deprived from providing that. I'm from Sri Lanka, low and middle income country. So, and I have worked in the Maldives also. Maldives has, compared to the Maldives and Sri Lanka, it is like drastically different provision of assistive technology. So some people we see that they have to even ration some splint sheets in the clinics as well. So in such situations, I know that the policies and guidelines and everything is there, but no coordinated mechanisms in the state levels. So in such situations, I know vice versa, different kind of advocacy work we can do, but still, is there a possibility or is there a mechanism that the global organizations because in our countries are like ours, mostly the medicine or like the initial care, the life-saving care is more prioritized and rehabilitation is frequently ignored. So I wanted to ask that if there's a collective, I mean, in the recent upcoming here process as also something like that to pressure the government, so like provide the state parties that some kind of limits that to provide at least minimum needs of assistive device for the person. Thank you.
Don't know who wants to take this question from the panel.
I can give you one very practical way to try and help with prioritising, because that's essentially what you're talking about. It's really difficult, and the reality is that in lower middle income countries there isn't the fiscal space within the health system to cover everything. So ministries of health, if we're talking specifically UHC, health services delivering, they have to make choices. So we, as advocates and technical advisors and supporters to member states and all of these things, we have to help member states work out what can they actually achieve that's affordable. And so the priority assisted product list is one solution from WHO, which has been used to help countries to begin establishing the systems that are needed to be able to effectively provide assistive technology. But it's a starting point. And so the first priority assisted product list in 2016 had 50 products on. The new one that will come out very, very soon has 68 products on it. I think I'm right, somewhere in the 60s. And it's a starting point for ministries across the 6 different functional domains to be thinking about the systems to provide those. So I guess that's an answer in terms of prioritising and where to start and how we can help. But I think we can, I think you're also talking about rehabilitation, so I'm very happy if, Amy or others on the panel.
Pascal would like to compliment.
There you go, thank you.
Just to add one point to your question around access and to assistive technology in countries like Sri Lanka, I think beyond what Kylie just explained, and this goes a little bit beyond UHC as well, but assistive technology and access to it and financing for it today is very fragmented. And in countries, oftentimes, it's split across multiple ministries. Right? Ministry of Education might have a little bit of budget for it, supporting inclusive education, and Ministry of Social Affairs might have budget for it because they're often in charge of persons with disabilities. Ministry of Education would have a budget for it as part of their efforts towards UHC and so forth. And even other ministries might have also. And so I think one also important step is to have stronger coordination at the country level across sectors, across ministries, because I think that will really enable a stronger response and hopefully some form of pooling of the limited resources that are there.
I think there was also a question, Dan. Yeah, thanks.
Thank you. Hi, everyone. My name's Sophie Plumridge from the Fred Hollows Foundation. Thank you very much for the conversation. It's really interesting. And I was particularly interested in the conversation around the indicators that you spoke about. We've had a similar challenge in the eye health space with the incorporation of indicators into the UHC index as well. and the indicators that we have are also around effective coverage, one around refractive error and the other around cataract. So I was wondering there might be an opportunity for us to work together when you were talking about the 14 indicators under the SDGs and the categories of population, outcomes, and then services. I wonder if there's an opportunity for that third category, which is more around the effective coverage, which you talked about. So would be very happy to have a further conversation, but I was also interested to know when the UHC indicators are next being reviewed as well. Thank you.
Thanks for that question, and absolutely open to having a conversation about that and, you know, collective action to review. In terms of those indicators, you know, it's quite a challenging and long process. The timeline, I don't know exactly. We'd have to come back. But as was noted before, the processes, even for the political declaration, which then would likely trigger a review in that political declaration, start soon. You know, the discussions that then would lead to the political declaration next year. So then we could probably see likely end of 2027, early 2028. If that's triggered, of course, in it. So I do think, you know, the advocacy and the conversations need to start now and here and today. So it's great that we're having that, and we can collectively look at how to move things forward.
And I think we can take one or two questions from online. Thanks. But we need to be mindful of time, so we will be quick.
We have there are two questions. We can. The first one is from Rawa Adam. In many low-resource and conflict settings, people with disabilities cannot access even basic assistive products due to displacement, poverty, or supply shortages. And then it becomes clear that that is also with specific reference to countries experiencing healthcare collapse and displacement, such as Sudan. And the question related to that is, what practical strategies are being discussed globally to make assistive technology affordable and accessible during humanitarian crises? And the second question is from Constance Mulenga in Zambia, who oversees the coordination of assistive devices. And she says that Kylie mentioned how the 5P framework includes strengthening systems and overall coordination of the AT system. My question is, for a country like mine, how are country-level collaborators coordinated to ensure ATs reach the right people and also to avoid duplication, as I have never come across a central database to track delivery of AT? Very practical questions.
Very good. So I think we have a question on access during crisis and emergency situations. I don't know who will. Yeah. Okay, very well.
All right, I'll take the first one then. On crisis, it is really a challenge, and too often in emergency response plans, this is not prioritized at all. And so we're trying to change that and advocating for that and working with OCHA and other players to make sure that in the guidance and that help prepare these plans, this is not forgotten or left as an afterthought. Practically, we have put in place a mechanism through the AT Scale partnership, which is a pre-positioning mechanism. So basically, we have a set of AT kits, and these kits is a predefined set of essential assistive products that have been defined by WHO and other partners, and they are strategically located so they can be rapidly deployed in times of crisis, be it a natural disaster or a conflict. And then it's a kind of a revolving mechanism that then gets replenished by the organization that's making use of those kits. But this is one way that we're trying to more rapidly address the needs that arise in cases of conflict. It's a small step. We'd like to make it a much bigger mechanism, but of course that is subject to more funding.
Okay, thank you. So just building on that, just to flag that the Rehab Alliance, I think many of you may be aware, are working on a toolkit to support preparedness, and that has a module on assistive.
Oh my God.
I was just checked in with Amy where that is. Oh my goodness, what was that?
It's a WHO toolkit, and that is valid.
Okay, it's a WHO toolkit. Okay, but with support from, okay. Right. And we're also, part of the issue around preparedness is making sure that we're pre-positioned. And so we're really happy through the work with the rehab team to have assistive technology positioned as part of the trauma rehab, trauma emergency surgical kit, correct? Yes. That really threw me, that noise. I was like, whoa, okay. Coming to Zambia, I'll go on to safer ground there. So I think the answer to that around bringing collaborators together, something that we have seen as a really effective tool, and I love it when I hear that countries are doing this, is to undertake a national situation assessment. And there's a couple of different ways that it can be done. Now, I'm in a mixed rehab assistive technology audience here. So we've got the STARS, which is the rehab situation analysis tool. And we also have as WHO, we have the assistive technology country assessment. And these are really great frameworks that can bring stakeholders together in a guided way to go through systematically the capacities within a country, and then to be able to plan from that information that is gathered. But I think one of the powerful things of the tools are that it actually brings stakeholders together. And often it will surface work that's going on in different pockets and different stakeholders that each other weren't aware of. So I really encourage countries that are struggling with this issue around coordination to think about using these sort of systematic tools. And you can approach the WHO country office for support in doing this work, and that will come through to the regional and the headquarter offices for support as a rule. And we will do what we can whenever we can to be able to support those processes. So thank you.
Thank you very much for your questions and the brilliant answers from the panelists. I would now give the floor to John Cauthen, Secretary General of the International Cerebral Palsy Society and Cerebral Palsy Europe. From a lived experience perspective, why rehabilitation and assistive technology cannot be left out of UHC, and why must health systems look beyond survival to address the broader spectrum of health needs?
Thank you, Valentina. So my lived experience is that I'm the parent of a 20-year-old living with cerebral palsy. And I think when we go back to the 5P framework and with the person at the center, and there's one aspect of today's session which is really important to emphasize, is that we have rehabilitation and assistive technology on the same panel, talking about issues which are dealt with in different departments at WHO, and we see across health systems how this fragmentation between different service providers can lead to gaps and to a lack of provision. Some of the work that we did last year with WHO on preparing the Global Action Plan on universal access to assistive technology really discovered the extent to which a lack of an ecosystem around the provision of assistive technology, and that ecosystem involves essentially rehabilitation professionals, can lead to products being neglected and wasted. So coming back to this point about the person-centered approach, if you think about the person and their needs and all the different aspects of their needs, then it's important that we have rehabilitation and assistive technology and indeed other sectors, because it goes beyond that, working together and in coordination. But I wanted to give the opportunity for some of our members in low and middle income countries to weigh in on this. And so we've compiled three little short, very, very short videos from them. And it seems that this is supposed to be set up for sound, but we don't seem to have it.
Assistive technology are not luxuries. They From my experience as a mother of a 20-year-old child with severe cerebral palsy who is totally dependent, and from what we see daily at CP Center, rehabilitation, especially palliative rehabilitation and assistive technology, make life possible and give children dignity. A child may survive birth complications, but without therapy, supportive settings, and other assistive technologies, the child is still excluded from education, healthcare, and community life. In low-income settings like ours, families, especially mothers, carry this burden alone. Universal health coverage must go beyond survival. It must also give people dignity, inclusion, function, and hope. Thank you.
In time of crisis and war, assistive products are often donated with good intentions. But when they are not adapted to the person's need, they can cause pain, complication, and exclusion instead of support. At Cezobel in Lebanon, I see every day how appropriate assistive technology changes lives far beyond mobility. A well-fitted wheelchair is not just mobility, it is access to school, play, participation, and inclusion. A communication device can become the voice of a child who has never been heard. Health system must go beyond survival. People with disabilities deserve dignity, inclusion, and participation. Assistive technology is not a luxury, it is a human right and part of universal health coverage.
I'll share with you the before, after, and present of Nestor Fabian Meza from Corrientes, Argentina. The story began in June 2024. Surgery on both legs marked the beginning of a great challenge, total reconstruction. Then came a new stage, entering the Mandic Institute for his rehabilitation. Those were months of effort, perseverance, and hope. Today, thanks to his enormous willpower, the work of many people, and the financial support of the Obligado Foundation, Nestor has a different life and a different future. A story of struggle, overcoming adversity, and new opportunities.
So just to sum up, I have to. What we see from the lived experience perspective then is that assistive technology and rehabilitation are not luxuries, even in the lowest income countries. That for persons living with disabilities in particular, they are access to community life, social participation, education, employment, healthcare, communication, and the list goes on. Access to assistive technology and rehabilitation is a human right, as was said very clearly, and must be integral to universal health coverage. Thank you.
Thank you. We are going to close with a few minutes delay, but we also started a bit later. So for all panelists, and here the challenge is to be very concise, to just highlight one key message to bring to the high-level meeting on universal health coverage. And yeah, maybe we can start from Joan and we go this way of the panel. Thank you.
So I'm just going to repeat again, it's a human right.
I think I'm just going to echo what was earlier said about partnerships, that it's really having a collective voice and going in together. So communication and partnerships.
Yeah, it's a sentence. It's a question that makes us repeat ourselves, I think, is that yes. Look, I would say assistive technology, look, it's an essential part of healthcare. It enables people's health, their well-being, their participation, their inclusion, and their realisation of rights. And yet we need to emphasise that at the moment, for too many people, the products and the services are either unavailable or paid for out of pocket. And I would probably flag that really, if we think about assistive technology needing to be embedded into health policy, financing, and service delivery as part of essential affordable care, that's exactly what the 5P framework is all about. Thank you.
I think that as countries are struggling right now with financing and all of that, really getting people to understand this cannot be put on the side, because some of these issues get put on the side and they prioritize as infectious diseases or something else. We can't wait, and we cannot. It's now. Now we need action now. That's what I communicate. Regardless of financial constraints, there's no excuse of that connection.
And I would just then add that, it's not just a human right, but it's actually a smart thing to do to invest in rehab and assistive technology, because there is a real return on that investment to not just the individual, but their family and the entire society.
Thank you very much to all the speakers today, the participants online and in the room. And if you want to stay a bit longer to continue the conversation in the networking space, you're welcome to stay with us a bit longer. Thank you very much.